Good afternoon. Thank you for this opportunity. Today I'm going to talk to you about uh, four success stories in an injury prevention public health approach to preventing suicide in England, Sri Lanka, and Samoa, and motor vehicle fatalities in the United States. I've been asked to talk to you about non-firearm-related violence and what that can help us, how that can help us think about how to prevent firearm-related mortality. And I'm going to do so by going over a couple of these success stories and the principles that they illustrate. Oops. They won't illustrate anything if I turn it off. Okay. Okay. So I'm going to focus on suicide for a few reasons. First, the mortality burden of firearm suicides is about twice the mortality burden of firearm homicides. Second, there's great variation, state to state variation in the United States, offering promise for prevention. And the evidence, the empirical evidence from case control studies, from cohort studies, from ecologic studies is really extremely compelling. And so I wanted to just let you know from the start that these lessons are those that I'm going to apply to thinking about preventing death by suicide. In the 1950s and before, the motor vehicle fatality rate in the United States was extremely high. Since then, the number of people dying per capita per mile driven has dropped by over 80%. It's one of the huge success stories that we have, and we have a lot to be thankful for the efforts by the CDC in that respect. Prior to 1950, the approach was to focus on the question who caused the injury, what were they doing, and efforts were made to try to change driving behavior, public service announcements, driver's education, and so forth. And it turned out it's actually very hard to change human behavior. And it's a lot easier to acknowledge that part of the spectrum of normal human behavior is to behave outside of the bounds of what you would like. And taking that into account, we redesigned the roads and the cars to better absorb the crashes, the energy that resulted when people behaved outside throughout the entire spectrum of human behavior. The central idea here is that you can actually prevent death by car accident either by getting people to not get into crashes in the first place, or by assuming they're going to get into crashes and making it harder for them to die given a crash. The same idea pertains to intentional lethal violence. What caused the injury when it comes to suicide? Again, we can decompose death by suicide into the likelihood of making an attempt times the likelihood of death given an attempt. And what largely determines the likelihood of death given an attempt are the methods that are used. Does the availability of a highly lethal and commonly used method affect the overall suicide rate? Well, the answer from a number of different studies is yes, it does, and it does sometimes dramatically. This is a famous slide by Kreitman, who talked about what he called the coal gas story. In the 1950s, in the mid-50s, the leading method used in suicides in England and Wales was putting your head in the oven, dying by carbon monoxide poisoning, because the concentration of carbon monoxide in coal-burning stoves, which were used to heat the majority of households, was extremely high, enough to result in death. What happened over the next 10 years is that gas was discovered in the North Sea, and it was detoxified. And as detoxified gas went into the homes in England and Wales, the carbon monoxide concentration in the heating went down to non-toxic levels. In tandem with the decrease in carbon monoxide concentration in homes, what you saw was a fall in carbon monoxide-related suicides for both men and women, the red line here. What didn't change was the rate at which people were killing themselves with non-carbon monoxide methods. The net effect was large. The net effect was a decrease in the overall suicide rate for both men and women, driven by a decline in the carbon monoxide poisoning suicide rate. And it's important to note here that roughly half of all suicides were due to coal-burning carbon monoxide in England and Wales at that time. During the agricultural revolution in Sri Lanka, pesticides were brought in to better tend the crops. One of the untoward consequences of that was that the types of pesticides that were brought in were the kinds that we would not allow to be manufactured here, not for fear of suicide, but because accidental contamination with these incredibly toxic products could actually cause grave illness and death. Suicide rates in Sri Lanka went up because pesticide-related suicide rates went up. And then the government enacted bans on some of the most toxic pesticides. And in tandem with those bans, you had a decline for both men and women, as illustrated in this graph, in the overall suicide rate that was driven, as you can see here, by a decline in the targeted method, in suicide by the toxic pesticides. There was not a compensatory increase in suicide by other methods to any appreciable effect. And here too, as in England, suicides due to pesticides were such a dominant method, you could actually detect a decline, and a dramatic one, in the rates at which people were dying by suicide overall. It's notable in Sri Lanka that attempt rates did not change. People were not attempting more often, but then when they were attempting with methods that did not prove equally lethal. You can also look at data from Samoa, where paraquat suicides went up and then down, just as they did in the coal gas story and in Sri Lanka. Well, what about the United States? We're here to talk about how to prevent lethal firearm violence in the United States. In the United States, half of all suicides are due to firearms. There were 19,000 firearm-related suicides in 2010, 38,000 total suicides in 2010. And this method, firearms, is commonly used, culturally acceptable, or it wouldn't be commonly used, and highly lethal. The distribution of death by suicide varies a lot more than the distribution of death by natural causes in the United States. It's the second leading cause of death among people under 40, the 10th leading cause of death overall. And when I showed this slide to psychiatrists at Grand Rounds and asked them, what do you think this is? They pretty much say that's a picture of the United States. So we're off to a roll there. But then when you start off with an easy question, right? And then I say, well, what do you make of the heterogeneity in suicide rates? I say, oh, that's interesting. I really didn't know it varied that much. It must be because rates of mental illness are a lot higher in the high suicide death states than in the low suicide death states. The rates of substance abuse, major depressive disorder, and other things. Well, it turns out that that's not what explains the variation, the huge variation in suicide rates across the US. If you look at the suicide rate, as I've graphed here, increasing from the left side to the right side, what you see is that various measures of psychological distress, whether you're looking at major depressive disorder, whether you're looking at anxiety disorders, whether you're looking at rates of suicidal ideation, whether you're looking at rates of suicide attempts, they don't vary in relation to the rate at which people are dying by suicide. What determines the heterogeneity? What is driving the curve up? Well, what's driving the curve up here is that rates of death by firearm suicide are higher in the states that have higher rates of overall suicide. The rates of non-gun suicide are really not that different. In a study that we did in 2004, this is sort of a microcosm of what you would see if I gave you a table of all 50 states or plotted it out. These are the states in the Northeast except New York. We didn't get data from New York. And what you can see here is that rates of household firearm ownership vary about threefold, from 12% to 45%. Rates of overall suicide vary almost twofold. Non-firearm suicide rates don't really differ. There's an indifferent relationship to household gun ownership and to overall suicide rates. But what drives the overall suicide rate is the rate at which people are dying by firearm suicide. And that is highly correlated with household firearm prevalence. There have been a lot of good studies by people, some of whom are in the room today, case control studies, a cohort study, ecologic studies, that show with remarkable consistency, looking at different populations at different times, that the presence of a gun in the home is a very strong risk factor for death by suicide, because it's a strong risk factor for death by firearm suicide. Rates of non-firearm suicide are not that different in homes with versus without guns. What you can see here is a table that we constructed with the high gun states compared to the low gun states. And they've been arrayed in such a fashion that you have similar populations in both columns, the high gun population and the low gun population. This is the population in these states between 1999 and 2007. And so you can see there are about the same number of people, or person years to be specific, in the high gun and low gun states. What differs between these two columns is the proportion of households with firearms. About half of all households had firearms in the high gun states. About 1 out of 6 had firearms in the low gun states. And as you can see here, the percentage of the population reporting depression or suicidal ideation, or in fact suicide attempts, is similar in the high gun versus low gun states. Now I'm showing this to you to give you a sense of the magnitude of the mortality differences between places that have similar rates of mental illness, similar rates of suicidal behavior, but different rates of death by suicide. And the differences are pretty huge. Look at the firearm suicides among women. Same population, so we'll just look at numbers over this time period. There were over 4,000 women who killed themselves with firearms in the high gun states. There are about 500 in the low gun states. The number of non-firearm suicides among women in the high gun and the low gun states, about 4,600, not really different. The difference in the total suicide rate is over 3,000 women. You get the same story for men. 26,000 firearm suicides in the high gun states, 7,000 in the low gun states. Similar rates and numbers of non-firearm suicide. We're talking about 18,000 more men dying by suicide overall in the high gun versus the low gun states. And you see a similar pattern for children. Now you can control for all sorts of factors at the state level. You can look at case control studies that have controlled for differences between households with and without guns, and you basically get to a first approximation this story. This gives you a sense of the magnitude that we're talking about and the number of lives that could be saved. So what are the ideas here? The ideas here and the realities are that suicide rates can be dramatically reduced without necessarily doing anything about underlying rates of mental illness or even underlying rates of suicidal behavior. Dr. Kessler has done enormous amount of really interesting work looking at suicidal behavior. And one of the studies looked at what happened in the United States between 1990 and 2000, roughly. Rates at which people had major depressive disorder, suicidal ideation, or suicide attempts didn't change, despite the increase in the rates at which people were being treated with antidepressants, let's say. But rates of suicide in the United States did decline. They declined by about 30% for adolescents and young adults, somewhat less so for the population as a whole. And what was responsible for the decline in suicide rates in the United States was a fall in firearm suicides. That fell in tandem with declines in household gun ownership. Rates of non-firearm suicide did not change between the years that Dr. Kessler assessed suicidal behavior between 1990 and 2000. So you see a similar secular change in the United States. And the ideas that we get from the motor vehicle experiment is that changes in the environment writ large, physical changes, environmental, legislative changes, and changes in social norms that have come up previously can actually have an enormous effect on rates at which people are dying. People are not driving safer, but they're driving in safer compartments. The roads have been made safer. And it's a lesson in the multidisciplinary approach from the motor vehicle success. Okay. Unlike the ban on toxic pesticides in Sri Lanka, which could be done by fiat in a centralized fashion. The most likely way to reduce population-level suicide rates in the United States is going to require a broader multidisciplinary approach, an approach that fosters informed decision-making by people in a household about whether, and if so, how to keep guns in the home. It's going to require a shift in social norms, as we've talked about previously. And it's going to also involve, or could also involve, the development of technological advances like personalized guns, which even if say the father in the home might be able to use it to kill himself, his wife and his kids wouldn't. So what recommendations do I have for the CDC? My chief recommendation is don't have me or anyone else here tell you what researchers should do in particular, but rather create an environment that fosters researcher-initiated work. Let 1,000 flowers bloom. In terms of some foundational research that might be considered, what factors govern the choice of method? And when a person's access to lethal methods are blocked, what determines the method, if any, he or she will subsequently use? How do gun storage practices affect the suicide rate among adults? We have a good idea from a limited number of studies that storage practices actually reduce the risk of suicide for adolescents and young adults, but we don't really know that for adults in general. And what about the factors that drive changes in the suicide rate among subpopulations like young African American men, whose suicide rate had traditionally been half of that of young white men until the mid-90s, when it rose to a point that it was as high as it was among young white men, and has declined, but not back down to baseline. And where do the guns come from in the suicides of young men of color in the inner city? That's also something that we don't know that much about. We need to better understand how people weigh the risks and the benefits of keeping a gun in the home, and about different storage practices. And based on that sort of formative work, what messages presented by whom and in what context best help people make decisions that they deem in their own enlightened self-interest. We need to conduct rigorous studies to evaluate the impact of lethal means counseling on decision-making in homes. And we need to scale up and institutionalize practices, lethal means counseling practices, in medical settings and in non-medical settings. This is my last slide, and I just wanted to offer a perspective on some structural changes within the CDC that could actually help. CDC should be insulated from political pressure. We should increase the CDC's internal capacity to conduct and superintend excellent firearms research. Leverage existing data systems to supply basic information that researchers need to adequately study firearm-related violence. Create a funding stream that allows me to tell my best graduate students that there's a future in doing firearms research, which I cannot in good conscience tell them today. And provide support for the leadership that exists to create a more capacious model of suicide prevention, one that focuses on this formula. You can reduce the rate at which people are dying by suicide, even without affecting the rate at which they're making suicide attempts, if you focus on making it harder for them to die in any given attempt. That's in your that's right there in your roundhouse. And thank you for your time.
Thank you, Matt. Our final presentation is Jacqueline Campbell, Professor, and Anna D. Wolf, Chair, Department of Community Public Health, School of Nursing, Johns Hopkins University.